Well, good morning to one and all present here. Today I'll be presenting a topic called differential diagnosis of cognitive decline in elderly. So, what is cognitive decline? It is an inclusive term used to describe any characteristic that acts as a barrier to cognitive process, including learning and memory impairment. It is one of the most prominent and debilitating consequences of normal and pathological aging in humans. So, as we know, aging results in multiple changes, and normal aging results in a characteristic change in many components. The first being sensory apparatus. There is decreased processing of sensory apparatus and persistence of what we call a stimulus memory. And there is a decreased sustained attention. Coming to intelligence, there is a preservation of what we call as a crystallized intelligence, but there is decreased fluid intelligence. It means like how a person becomes more rigid as he gets old. And the next would be intelligence quotient. There is a decline in performance intelligence quotient, but there is a stable verbal IQ. And as the person ages, his narrative style becomes more richer and there is decreased active naming. And we all know that there is decreased memory with aging. To be more specific, there is decreased in the primary and working memory and decreased retrieval of stored memory. And there is sleep fragmentation, there is increased fragmentation and decreased REM sleep. So next, we're going to talk about the different cognitive domains. The DSM-5 defines 6 key domains, the first of which is cognitive function. So there are totally 6 domains, and the first one being complex attention, executive function, learning and memory, language, perceptual motor control, and social cognition. So let us talk about complex attention. So what is that? It is the ability to concentrate multiple things at once. The next would be executive function, which talks more about planning, prioritizing, making decisions, and organizing a set of tasks. And the next would be learning and memory, which is a well-known aspect of cognition, and it refers to the ability to record and retrieve information as needed. And then would be language, which is the ability to communicate, and then the perceptual motor control, which essentially means the ability of one to coordinate with the environment and to interact with the environment with our sensory system like vision, touch, hearing, etc. And the next would be social cognition, which refers to how we process information with respect to social context, our behavior, and our facial expression, etc. And why is it important to know these cognitive domains? Because several of these key domains are affected in the various neurocognitive disorders, and we test them during the various neuropsychiatric assessment as well. So this slide depicts about the various innumerable causes of cognitive decline in elderly. This could be the major degenerative dementias like Alzheimer's disease. It could be PICS. It can be metabolic abnormalities involving kidney or liver failure. Can be endocrine abnormalities like hypothyroidism, vitamin deficiencies, or it can be depression, which is an important differential and is often called as pseudodementia. And the next would be delirium, which is a waxing and waning kind of cognitive decline, which usually results abruptly. Cognitive decline can also happen in general neurological conditions like trauma, tumor, multiple sclerosis, Parkinson's, Wilson's, and etc. So why is it important to know the different causes of cognitive decline? Because sometimes it can be a readily treatable cause of cognitive decline, and some degenerative dementias do have a symptomatic pharmacotherapy. And by properly diagnosing the cause of cognitive decline, this helps in long-term planning since the patient and the family will get to know more about what they're dealing with. And this kind of facilitates the research efforts as well and also helps in support group participation. So before jumping into the peculiar aspects of each different kind of a disorder, we will have a brief idea about the spectrum of severity of cognitive deficits. So we're going to talk about the differences between mild cognitive impairment versus dementia. So what is MCI? It is a stage of transition between normal functional ability and a full-blown clinical picture of dementia. So it can be defined as a cognitive decline, which is abnormal for age and education of a person, but it does not interfere with the function and activities. So what are the main four subtypes of MCI? They include AAMI, age-associated cognitive decline, amnestic MCI, and cognitive impairment. The subtype of MCI called as the amnestic MCI is where the memory loss predominates, and this has about 15% year of conversion into Alzheimer's disease. On the other hand, dementia, it is not just senility, it's much beyond. So this slide, it's going to tell us the definition of dementia. It is basically an impairment in intellectual function, which is affecting more than one cognitive domain, which interferes with the social or occupational function. And there is an obvious decline from a previous level, which cannot be explained by delirium or any other major psychiatric disease. So this slide beautifully depicts the spectrum of severity of cognitive decline, starting from the preclinical stage to the MCI and then dementia. So we can essentially say that MCI and dementia, the defining difference is the degree of functional impairment and cognitive decline. So now we will have a peek about the various different pathologies leading to cognitive decline. Each pathology could be a presentation on its own, but here we will restrict to the most distinctive features and how we'll be able to differentiate one from another. So it's essential that we start the discussion with normal aging. Normal aging is characterized by general loss of brain volume, especially the white matter more than the gray matter. And it typically has an insidious onset happening somewhere between the 6th and 7th decade. And there is a mild decline in cognitive function. The characteristic thing is that the type of memory which is affected and preserved. The episodic and working memory are affected first, but the procedural and semantic memory are typically reserved until the very last. And another important feature is that the independence in daily activities is typically preserved. Next, we're going to be talking about pseudodementia. And this is a very important term which refers to the structural or metabolic abnormalities associated with depression. And it is a major mimic of dementia, especially in the elderly people. It is important to pick this out because here the cognitive deficits will typically manifest after the mood symptoms, and the cognitive decline usually improves after antidepressant therapy. Next, we're going to talk about we're going to start with the major four dementia. So first, we're going to talk about the Alzheimer's disease. So it is a progressive disease, which usually happens over 8 to 10 years and is characterized by the presence of what we call the neurotic plaques or the neurofibrillary tangles in pathology. Neurotic plaques are nothing but amyloid beta plaques, which get accumulated extracellularly. On the other hand, neurofibrillary tangles are abnormally phosphorylated tau protein, which gets accumulated intracellularly. The main thing to keep in mind is that the memory impairment in Alzheimer's is typically episodic, and the characteristic order of language impairment goes such that first, the naming is affected, followed by comprehension, and finally, the fluency of the language is impaired. Alzheimer's is typically a clinical diagnosis, and on MRI, we will be able to find diffuse cortical and hippocampal atrophy. On the other hand, the next entity called dementia with Lewy bodies, in contrast to Alzheimer's, which has a progressive decline, DLB would have what is called as a steady decline, which would again span over somewhere between 8 to 10 years. But a characteristic finding is that It will be usually associated with symptoms such as visual hallucinations, Parkinsonian kind of motor disorders, and attention impairment. And on the SPECT scan, it reveals reduced occipital perfusion and metabolism. So this MRI beautifully depicts the difference in the brain of a healthy control versus Alzheimer's disease, wherein you can see the diffuse cortical atrophy and the hippocampal atrophy as well. So next is the frontotemporal dementia. So here it usually manifests between the age of 40 to 69. And the behavioral variant of FTD, which is the most common variant, results in early change in personality along with the cognitive decline and also apathy and other features. The PET or the SPECT will reveal a metabolic disorder in both the frontal and temporal parts of the brain, and so does the MRI reveal atrophy in the same areas. The next disease will be vascular dementia. And here, this disorder has a cerebrovascular pathology and presents with what is called as an abrupt cognitive decline and stepwise deterioration. And another striking characteristic which could differentiate this from other dementias would be the presence of focal neurological deficits like hemiparesis. And on CT or MRI, we would see the multiple white matter lesions or infarcts, the cortical and the lacunar infarcts. Now we're moving on to the much rarer causes of cognitive decline. And the first would be normal pressure hydrocephalus, which is a potentially reversible cause of cognitive decline. So it is characterized by a classic clinical triad of gait disorder, dementia, and urinary incontinence. And on MRI, we would see relative dilation of the ventricles with periventricular hyperintensities. This is very important to know because it's a potentially reversible cause of cognitive decline, and a simple lumbar puncture would alleviate the symptoms. Next, moving on to Parkinson's. Parkinson's disease patients, cognitive impairment develops only in advanced disease and is characterized by usually has the clinical symptoms of bradykinesia, resting tremor, and rigidity. It will be characterized by progressive dopaminergic neuron degeneration in the substantia nigra and the locus ceruleus. The other rare condition is a Wernicke's encephalopathy and Wernicke's-Korsakoff syndrome. This is again another potentially reversible cause of cognitive decline and has the classical clinical triad of confusion, ataxia, and ophthalmoplegia. Wernicke's-Korsakoff syndrome, which is the chronic entity of Wernicke, it is characterized by a severe anterograde and retrograde amnesia, coupled with confabulation, which is nothing but the patient making up stories to compensate for the memory loss. And the pathology reveals gliosis and inflammation in acute WE, and the Korsakoff syndrome will have atrophy of mammillary bodies. Next, we're going to late neurosyphilis. Cognitive decline in neurosyphilis would occur years after the primary infection, say 20 years after the primary syphilis infection. The main characteristic clinical features include frontotemporal dementia along with psychosis and other personality changes. Other specific features of neurosyphilis, such as paresis, Argate-Roberts in pupil, or tabes dorsalis, could coexist. Positive screening and confirmatory treponemal tests would help us in the diagnosis. And the next disease is a prion disease called the Creutzfeldt-Jakob disease, which is nothing but a spongiform degeneration of the brain, which is intracytoplasmic vacuolation of the neurons. And the characteristic kind of dementia in a prion disease would be rapidly progressive dementia, which happens within weeks or months. And another interesting thing which usually coexists is what is called as a startle myoclonus, which is a myoclonus triggered by startling loud noises. It can be confirmed by the presence of a protein called 1433 in CSF, and the EEG would reveal triphasic periodic sharp wave complexes in the range of 1 to 2 Hertz frequency. The MRI would show hyperintensities in the basal ganglia and insular cortices, which is what we famously refer to as the hockey stick sign and the cortical ribbon, etc. And finally, we're going to talk about Wilson's disease, which is a disease of copper accumulation. It begins with subclinical hepatitis and progresses to liver cirrhosis, and the neuropsychiatric symptoms start. It gets involved if it is left untreated for a very long time. On slit lamp examination, we would find the Kaiser-Pleasure ring, along with the extrapyramidal motor disturbances which occur in this condition. It can be diagnosed with special testing like ceruloplasmin testing, which will result in increase free serum copper and reduce serum ceruloplasmin. Next, we're going to talk about the various diagnostic methods. Now that we have seen the various differential diagnoses, the basic lab panel which can be tested in these patients include vitamin B12, TSH to rule out hypothyroidism, CMP to look for liver and kidney diseases, urine analysis to rule out infections like the urinary tract infections, ESR, CRP, and ANA to look for any inflammatory or autoimmune conditions. And we can do an RPR or Lyme titers if there is clinical suspicion of neurosyphilis or neuroborreliosis, respectively. HIV screening can be done to rule out HIV-associated neurocognitive disorders. And if a person exhibits clinical symptoms of Wilson's disease, then special tests like ceruloplasmin can be warranted. Other additional studies which can be done include a urine tox screen, especially in young patients, and imaging studies such as brain MRI, which is a perfect modality to detect reversible or structural causes of dementia. A lumbar puncture can also be done to assess for evidence of CNS inflammation or prion disease. It can also be done to detect specific biomarkers in Alzheimer's disease, and it can also confirm normal pressure hydrocephalus by what we call as the CSF TAB test. The PET scan or SPECT is used to distinguish between specific neurocognitive disorders, and EEG can be done to evaluate for seizures, subcortical dementia, and frontal lobe degeneration. So next, we're going to talk about the cognitive assessment. There are many screening tools for assessing cognition, but they're essentially only screening tools. And a more extensive screening tool, example, the mini mental state examination or a Montreal cognitive assessment can be done. This can be done for diagnostic clarity and to assess the degree of cognitive impairment. And the most common screening test that we use here in the clinic is the mini mental state examination, which is a 30-point questionnaire developed by Dr. Marshall Falstein back in 1975. It's a proprietary test, and the scoring ranges from 0 to 30, and less than 24 suggests that a person has cognitive impairment. The domains tested in this test include complex attention, language, learning and memory, orientation to person, place, and time. But the thing that we have to keep in mind is that this MMSE is just a screening tool and should never be used alone. It should always be used in conjunction with the corroborative history. So this picture depicts about the MMSE, the questions asked, and how we're going to evaluate the patient based on this test and would see how much he or is going to score out of 30. Next, we're going to talk about the management approach. So what we've learned from this presentation is dementia, it's just not senility, it's much beyond. And it is crucial that our HPI and exam has to be done very well. And it's critical because there are a lot of treatable causes of dementia. So if we do find one specific cause, then it is essential that we provide disease-specific treatment if it's available. And we need to treat the patient holistically by initiating supportive management and management of other associated conditions like neuropsychiatric conditions or other conditions like malnutrition and weight loss or fecal and urinary incontinence or infections associated with it. Everything has to be treated. And it's also essential that we arrange support for patients both patients and the caregivers. And we can consider referral to hospice for eligible patients because behavioral problems and fecal incontinence usually result in caregiver burnout, and that's going to result in poor outcomes for the patient. It's also essential that we encourage a healthy lifestyle, including diet, sleep, and personal hygiene. And finally, we can talk about the pharmacological treatment which is now available. There is no current treatment which can slow down the neuronal loss in the brain, but some anti-dementia medications may provide modest benefit for cognitive symptoms in some types of dementia. So the cholinesterase inhibitors, example the donepezil, rivastigmine, and galantamine, have modest symptom improvement in Alzheimer's disease. Sometimes they also result in marked improvement in other kinds of dementia, like the dementia with Lewy body or Parkinson's dementia. And finally, there's another drug called memantine, which is the NMDA receptor antagonist, which has shown to give modest benefit in moderate to severe Alzheimer's disease. Thank you.